دكتور وليد. دكتور سعيد النجار مش موجود. دكتور عوني مكانه. دكتور محمد البكري. دكتور محمد البكري موجود كان. وين محمد البكري؟ دكتور حسين العمرات، مهند عبابنة، وأسامة عكي.
I think in the interest of time we should start. This is the second session about complications. I urge speakers to stick to the 7 minutes allotted time. Our first speaker is Dr. Ahmed Hamed from Palestine. He is going to talk about SVG perforation. The floor is yours, Dr.
Thank you for having me. I hope everybody got caffeinated. This is our case, and I hope everybody learned something from it. I personally did. This is a 45 relatively young patient with multi-cardiovascular risk factor. He's diabetic, active smoker with a positive family history of ischemic heart disease. He has a significant past history of coronary artery bypass, LIMA grafted and SVG to diagonal, RCA and OM. His presentation, he's quite presented to a primary hospital with a progressive worsening of his angina. Due to the concern, he was admitted under observation. During the admission at night, he developed a slightly ST segment elevation in the lateral lead. Well, the admitting physician, he think it's appropriate to give this patient a thrombolytic therapy because he is in a hospital incapable of PCI center. So we're dealing with a post-cappage patient, recent thrombolysis, and was transferred to our center. We've seen him after thrombolysis, around 10 hours after thrombolysis. He was notably tachycardic, no raised GVB, nothing remarkable in the examination. Maybe there was a slight ST segment elevation in the lateral leads. The echocardiography was a preserved ejection fraction with hypokinesia in the lateral leads. The catheterization was done by one of my colleagues and was presented at that time and helped in assessing the complication. So exactly what happened, they did the imaging, and as you see the lift system, you can appreciate the OM obstruction, the total occlusion. Maybe you can follow there is a competitive flow in the LED and the diagonal branch. The RC is grafted, the graft is working fine. They did the images including the LIMA. The LIMA is patent, minimal lesion in the LED, and my colleague think it's a fairly direct approach. We have a lesion in a mid at the site of anastomosis of the SVG to the OM, and he think at that moment it's appropriate to go for direct stenting. Troponin is elevated, this patient's thrombolized, he's gonna short the time of the operation. And that's what he did. He go for stenting. He defined the lesion and he put the stent, and this is what we have. Exactly after the inflation of the balloon, and you can recognize the horrible perforation. It is not a perforation, it's a horrible extravasation. The patient collapsed, arrested, get hypotensive and crushed. And the operator got panicked. He called everybody. I was presented, and this is what we have. And this is what we face. Our colleagues speak about the classification of the perforation. You don't need to know the classification to understand you are in a big trouble. We have a massive extravasation and how to deal with it. For the interest, it's Alice class 3, perforation, active extravasation. What are you gonna do for this patient? Number one, and always number one, you need to stop the bleeding by inflating a balloon. Whatever you have, go and inflate the balloon. Then you think, you don't panic, you don't do anything. I join here and I start managing this case. The first thing we did, we inflate the balloon and stop the perforation. And immediately we did a pericardial synthesis. And if you notice, you see the right atrial collapse, even the small portion of time that took for maybe a couple of seconds without inflation of balloon caused a significant hemodynamic compromise because of the severity of the effusion. And here is, you need to think about the definitive management. Our colleague, they told us, maybe most of the time you get away with rapid exchange technique. You don't do anything, but not in this case. This case, you need to do like a proper management. So what is determined to do, what is the management here? It's determined in the guiding size and the severity of the perforation. If you have like a 7 French, an 8 French guiding, you can manage this case with a single guiding catheter. But if you have a 6 French, like our case, it is extremely difficult to manage it with a single technique. So it's well prescribed. Maybe some of our colleagues never use it, but you have to keep it in your mind. Sometimes you need those advanced techniques. The double catheter technique, which is called the ping pong technique. Basically what I did in this patient, I go with a second catheter, we get a femoral approach, we disengage the left main, and if you notice, you will see the wiring. We wire behind the inflated balloon. I do what is called a temporal deflation, and I pass my wire. When I pass my wire and everything is good, I already advanced my covering stent, and the covering stent is over there. And if you see the contractility, the patient is dying. Temporarily, we deflate the balloon and we apply our cover stent. What happened after? There's a minimal leak after. It was a 4O covering stent. I go with an NC balloon, elevated 1-to-1 pressure, and after that, what happened? You have a complete sealing of that perforation. This is our final image. So, step 4, we always think about anticoagulation. Do we need to reverse in this patient? We got the situation under control. We have a dying patient, he's hemodynamic instability. You have to keep it in your mind. Do I do a protamine sulfate reversal? Do I need to do a protamine sulfate reversal? Number 2, the patient's thrombolized. Hey, wait a minute, it's more than 24 hours. The altiplay is not there, but you have to keep it in your mind. At that moment, what I decide, it's nothing will harm if I give a tranexamic acid. We reverse the altiplays. The time of thrombolysis is less than 12 hours. We give him a lot of bloody products. He took like 3 units of bloody products immediately. The heparin was partially reversed, to be honest with you. I don't like to do a complete reversal. And if I want to do a reversal of any kind, I have to get all my hardware out of the coronaries. I don't do a reversal when I have wires, when I have balloons. It is extremely dangerous. And you need to think about the patient. This is an SVG perforation, and the SVG usually runs in the epicardial course. It is rather cause a pericardial effusion than, a pleural effusion than a pericardial effusion, and you have to think it. And this is the only patient that he has both a pericardial and a pleural effusion. The patient was safely discharged after 2 days of hospital course, and everything is well done. Recent thrombolysis, what I learned from the case, and the recent thrombolysis, even how simple you think the patient is not simple. This will maybe turn to a complicated patient. Even a minor perforation in a thrombolized patient can lead to a major complication. SVG's intervention, they are thin, they are degenerated, fragile, and they're prone to a complication during the intervention. You need to recognize the complication. You have a hypotension, chest pain. During the cath lab, always think of perforation. The post-cappage patient, the SVG's track, extrapericardial, it's lead to pleural effusion rather than a pericardial effusion. Don't panic, call your seniors. Think of reversal after you're finishing your case if it is. And you always think about definitive management, and definitive management is a cover stent in this case. And don't forget to call our colleagues in the surgery. They are our backbone. And thank you very much. Thank you for having me.
Thank you, Dr. Ahmed. We'll leave the questions to the last. My colleague,
Our second case will be presented by Dr. Ishraq Alhomani from Prince Hamza Hospital. She will present a nice case, left main stenting in a patient's post-CABG who had severe stenosis of his proximal subclavian artery and steep syndrome.
Good afternoon, everybody. It is a great honor to stand before you today. Thank you, Dr. Mahmoud. Thank you, Dr. Mahmoud, and it is a must to express my deepest gratitude to my role model and supervisor, Dr. Hussein Al-Amrad, for all his support and trust. Our patient is a 74-year-old male patient. He's a known case of coronary artery disease, hypertension, dyslipidemia, and COPD. He's an active smoker. He has a history of cabbage for one vessel in 2006 in USA, and it was LIMA 2LAD, and also RCA PCI in our hospital, Prince Hamza Hospital, at 2023. Patient presented with anginal pain and a left arm fatigue. Actually, it was intermittent claudication of left arm. ECG was not significant, no acute change. Blood pressure, I will mention this. Blood pressure for the right arm was 145/86, and on the left, it was 128/70. Saturation was 90 to 92 on room air. Echo was with normal ejection fraction and grade 2 MR. So due to weak pulse on the left radial, we went for femoral, and in this, and you say that there is significant 70% stenosis of the external iliac artery, but even with this stenosis, patient reported no intermittent lower limb claudication. After that, we goes for diagnostic. We found that there is distal left main critical tight lesion with proximal long segment severe LAD disease. This is another view showing that there is antegrade retrograde filling of the LAD with competitive flow on the LIMA. This is the RCA, nice RCA patent stent with collaterals to the left. Then we went for a LIMA angio. We found some resistance during trying to engage the LIMA. Then we take a picture. We found a complex ulcerative, okay, wait. A complex ulcerative significant lesion. خلاص بس خلاص. Then, so we are facing a case of coronary subclavian stale syndrome. So what to do next? We stopped the procedure at that time. Team discussion were formed, and options were either for subclavian BTA stenting or for native left main LAD stenting. Due to many reasons, we go for LAD saving through left main after 1 week. So this is the PCI of the left main LAD. We goes with wires, pilot 50, and ballooning PTCA with multiple size of compatible and non-compatible balloon. I will show you the final result because of time. This is after PTCA. Then we tried to go with stent. Actually, there was difficulties with, so we changed the catheter to EBU. First stent deployed, and this was the second stent. It was 3.5 by 23, and this was the last stent. This was the last picture, the final result. It was optimal for us. This is the final result. So this our procedure. I will skip for that. Outcome and follow-up: 100% procedure success. TIMI3 flow. No in-hospital complication. After 24 hours, patient ambulating, no access site complication. 3 days patient discharge on optimal medication. After 1 month, our decision as before for second session for proximal subclavian revascularization. So we go for subclavian revascularization through left radial with backup of right femoral artery. So as we mentioned, we used a vertebral catheter, glide wire, then direct stenting with self-expandable balloon, about 10 by 57. Excellent result, no more stenosis. So why LIMA failure is underdiagnosed? Standard angio often reveals a patent LIMA, masking the hemodynamic impact of upstream subclavian disease. More than 15 millimeter mercury inter-arm systolic pressure differences is a key screening sign, but absent in mild cases. So also rationale for native left main PCI strategy, revascularization, the native coronary bypass depending on LIMA flow under a protected left main PCI has evolved significant with modern drug-eluting stent, making it a viable strategy in selecting high surgical risk patient. So as we mentioned, the stenting of the proximal subclavian stenosis provide optimal result. So the key message, subclavian artery stenosis proximal to LIMA origin is an important and potentially underdiagnosed cause of recurrent angina after CABG. Inter-arm blood pressure differences and CT angios are the key diagnostic tools. When percutaneous or surgical treatment of the subclavian regions carries prohibitive risk, native coronary revascularization offers an effective alternative strategy to rescue LAD or restored LAD perfusion. Multidisciplinary heart team discussion is essential. Anatomy, operator expertise, and patient risk profile should guide the individual's revascularization plan. Long-term surveillance of both left main stent and subclavian lesion is warranted to detect stenosis or disease progression protectively. Thank you.
Thank you, Dr. Ishraq.
الله يمسيكم بالخير. الله يمسيكم بالخير. Our next speaker, Dr. Qaisi al-Balbisi, he is talking about closing the floodgate, percutaneous management of a giant coronary fistula in an ectatic vessel.
Thank you for inviting me and thank you for the introduction. Unfortunately, that case was supposed to happen. It was actually a huge coronary fistula that's emptying into the right atrium. We were considering closing it through a plug, but going retrograde. But the equipment that we needed never came, so I don't have that case. So I'm going to present another case, which is, and I'm going to highlight a certain topic, kind of similar to what we're talking about, and I've got the permission of Dr. Mahmoud to actually switch the lectures. Kindly, he agreed. So this is breaking the unbreakable, conquering complex lesions with IVL. And basically, I want to talk about a specific type of calcification. I know we spoke about a lot of calcification, rota, atherectomy, all those things, but one specific type, which is called coronary calcified nodule. This is an entity that we need to become familiar with, has certain specifics, certain implications that we need to be aware of. So I'm going to try to kind of go over it quickly in the respect of time. Our patient is a 58-year-old gentleman, vascular path, coronary artery disease. He actually had triple vessel disease, but he refused CABG adamantly. I spoke with him multiple times. He wanted to go for PCI. So we did the LAD and RCA before, and we staged the PCI of the circ for later on. He does have heart failure, end stage on hemodialysis, diabetic, hypertensive, continues to have chest pain. So, you know, the usual, typical kind of advanced disease. Now, this is his angiography. This is the right, you know, after being fixed before. And this is the LAD after also being fixed. So, looks good. And then, all right. And this is the circumflex. I want you to pay attention right here, right at the ostium of the circ. And you see this kind of notch. And this actually notch is going to be a nightmare for us. And then here, this is again, it's not as noticeable. You can see why we do need always two orthogonal views. One view is never enough, especially in eccentric lesions, because it can really hide the severity of the disease. So, moving on. So now, why is it? Okay, there you go. So this is just as a, and you can see all of us, we can see right there, there's this notch. Is it showing up? Okay, let me just do this. Pointer, thank you. So right here, you guys see this is like this small notch. So this is what we usually call, so what do you want to do next? How are you going to tackle this type of a lesion? So again, just a brief review, coronary calcified nodule. What is a coronary calcified nodule? First of all, it's not uncommon. It's around 7% of acute coronary syndromes, and 30% of patients who have acute coronary syndromes in general might not have it in the coronary nodule, but can have nodules elsewhere. It's a very common, and it's more common in elderly and hemodialysis patients, like our patient. Also, it's common in right coronaries at the hinge points and proximal segments, especially ostial, like our patient. What I do need you to pay attention to is coronary calcified nodules have this thing. If you don't treat them, they're stable, as long as they're stable. They have good outcome. If you put a stent, that stent over the coronary nodule or the calcified nodule has a more chance of becoming instant restenosis down the road. The idea is this, there's calcium sheets and then there's weakness at the hinge point, which creates a nodule that is free, and then this nodule can either hurt the vasa vasorum and cause local bleeding, or can perf the endothelium and cause an acute coronary syndrome, or becomes healed fibrotically, or complicated by a lipid core on top of that nodule, or more calcification. So there's different types of it. But the two major types that you need to be aware of is what we call eruptive and non-eruptive. The eruptive is the acute coronary syndrome. The non-eruptive is the stable one. Angiography can be very deceiving. Sometimes you cannot pick it up. You know, it can be a small blip. So, and yet it's going to cause problems. Usually you'll need intravascular imaging. Now, IVUS is useful, but not the best because it has a big shadow, this calcium nodule, and you can't see the exact details of the inner lumen, whether it's, as I said, a simple unprovoked one versus the acute, the stable one. OCT is very useful for such patients. Again, they're eruptive and non-eruptive. Eruptive is more acute, and there is this, you know, clot and irregularity versus the one. Another concept you need to know is what we call protruding calcium versus calcified nodule. Protruding calcium is an external calcium that comes in the view. And the way to recognize it and differentiate it from the calcified nodule is that you have this lamina and there is not much of acoustic dropout here. That goes with the protruding calcium rather than the calcified nodule. Advanced fluoroscopy helps, especially the stent boost, but is not enough. So how do we treat? Usually depends whether it's eruptive or non-eruptive. We start with high pressures, 1-to-1, NC balloon. If it is deformable, that's great, we move forward. If it's not deformable, we should not put a stent, because then you have worse complications. And this is basically what we did. So we went in and we basically, can you play, please? All right, there you go. So you can see no device would easily cross. So what we did is we started with regular ballooning, we made way, but still it would not expand fully. So what was our solution? We did, what would we do next? We chose IVL because it's an eccentric lesion and we were worried that, you know, rota would cause more problems. So we went with lithotripsy. This is the lithotripsy going in. And then we went in with the stent and it responded very well and opened very well. This is post PCI. You can see the hinge point went away. All right. So again, quickly, I don't want to take too much time. There is the roller coaster comparing IVL versus rota for calcified nodule, and it turned out to be better, lithotripsy, supported by another meta-analysis and also a third meta-analysis. with more likelihood of success and less likelihood of complications. So in short, be aware there are two types of nodules, eruptive versus non-eruptive, and you start to see whether they're compliant, they're going to expand with you or not. If they don't, you consider IVL. There is the dual hybrid approach, but that's for extreme cases, and you really need to be careful not to perforate. The problem with, on my last point, the problem with ROTA is the wire bias can increase the risk of perforation, and yet you might get to a point where you don't hit the nodule at all. So actually what you need to do is you need to upsize your burr to get it, which increases the risk of your perforation. So that's why ROTA is a bit difficult. Orbital might be an option, but really there's no good data on orbital for calcified nodule. Thank you so much. Appreciate it.
Thank you, Dr. Qais.
Dr. Muath Alkurdi, he will represent the next case, left main occlusion, a nightmare in Cath.
السلام عليكم، مساء الخير. شكرا دكتور محمود وشكرا للسادة الكوميتي بالجمعية. Our case is 65-year-old gentleman admitted via ER, simple case, chest pain, 3 hours, shortness of breath, sweating, typical pain, stable vital signs. ECG unremarkable. Troponin positive, HB hemoglobin 15, creatine 0.9. Rapid echo showed normal LV, ejection fraction 65, normal RV, pulmonary pressure 30. We went to transradial catheter approach diagnostic Cath. The Cath showed there is separate ostium or short left main with multiple MALDI plaques in the mid LED. This is a cranial view for the LED. And there is, stop بالله هنا, mid-circ tight lesion toward OM1. If we can stop. Yes. This one. So, this is type A lesion, mid-circ on bifurcation. Our plan is easy. Our fellow just want to do direct stenting or pre-dilatation for this lesion and put a stent. The RCA is dominant with multiple MALDI plaques. What's your opinion? PCI for this mid-circ lesion. Okay, my friend, get your EBU guide, put a wire, and we will do it easily. And this is what happened. I am a step back from my colleague. I see this thing. What is this? This is dissection. This is a catheter-induced thrombus. This is a spasm. What is this? What to do? Don't be panic. Thanks God, the answer come very soon. Okay? This is abrupt vessel closure with differential diagnosis. Just open the Y connector. When I opened the Y connector, this is what happened. A gush of air comes suddenly with severe pressure. So my differential diagnosis now is one diagnosis. This is massive air embolism inside the coronary. I told my friend, don't be panic. This is easy. This is easier than this is bilateral thrombus in the LED and CER. So we will manage this as massive air embolism. What to do? I took the guide wire from the CER, put it in the LED. Now the patient is shouting of chest pain within 30 seconds. Hypotension, ECG on the monitor. This is the ECG. It was totally normal on the monitor. I called, ask for CPR, let anesthesia be there, start CPR team to be standby. After 1 minute, this is what happened. The patient developed VFib. DC shock, CPR started, chest compression, intubation and mechanical intubation and mechanical ventilation. This is my job to break these massive air embolism. first in the LED. So I wear the LED, balloon massage was very rapid on the table, and asphalt aspiration catheter was used with multiple puffs with no flow at all. After giving of epinephrine intracoronary, then the pressure is going up. We gave adenosine, nitroglycerin, and this is the angio after all of these manipulations. Now the patient is stable. His blood pressure is 140/90. Everything is okay. TIMI3 in the LED with no flow in the circ. The problem, I think, I don't like this EBU guide. It goes deep always in the LED or always deep in the circ. So I changed the guide to less aggressive guide. Judkin left. I took this picture after stabilization of the patient. Wiring of the circ, tackle the lesion with direct stenting. Okay, we are now to go out of the cath lab as soon as possible. Okay, there is multiple thrombi in the proximal circ. Okay, we put another stent to fix these thrombi. Even after using of aspiration catheter, it does not gun. So this is the last result for this easy or was easy, very simple type A lesion in the circ. And thank you very much. Patient discharged on the next day. He was intubated just for 2 hours, extubated after 2 hours, and stable the next day without any neurological deficit. And thanks God for this management. Thank you very much.
Thank you, Dr. Muath. Is our next speaker here?
Our next speaker, Dr. Fadi Al-Qaisi. Our colleagues, you find him everywhere in Jordan, in Ramtha, and in Amman. I think the next will be in Aqaba, maybe. Welcome, Dr. Fadi.
تسلم دكتور شكرا كثير. Thank you everybody and شكرا استنيتوا لاخر شيء الدكتور محمود اختار انه يفتتح فيه ينهي فيه. ف I don't have, it's not a complication case, but it's a good case for educational, I hope. So the title is Graft, I miss you. I have no disclosures. 63 years old lady presented in June 2025 when I saw her with external chest pain, shortness of breath for 3 months. She's known case of hypertension, diabetes, coronary artery disease. And this is her story with the coronary artery disease. She was diagnosed with multiple coronary artery disease. And in September 2024, she underwent CABG by 2. She had LIMA to the LOD, venous graft to the OM. The report from the operation said LIMA occluded during surgery, and they had to replace it by a venous graft to the LOD during surgery. May 2025, she was still having chest pain. She went back to the same facility, and they found out that the LOD native is totally occluded. All grafts documented to be occluded. She was offered angioplasty for the proximal RCA with 1 stent and angioplasty for the proximal left circumflex artery bifurcating with the first obtuse margin with 2 bifurcating stents. So RCA saved with the stent, OM left circ saved with a stent because the RCA did not have a graft to begin with. Left circ lost its graft and the LAD is occluded and the graft for it was assumed to be closed. This is her medications and usually the usual suspects, dual antiplatelets, anti-anginal medications. Yet, the patient is feeling pain. This is her presentation in May when she needed the stents, troponin slightly elevated, but everything else is within accepted levels. ECG during the May did not show significant change and non-specific. And this is her echo when I talked to her. So we assume right now, LAD totally occluded, and no venous graft, and no collaterals. So we don't know where is the LAD coming from. And this is her, the echo. Can we have the automatic? It's an auto. So, mild mitral valve regurgitation. And you can see here that the LAD territory is moving. She has a low normal ejection fraction. So my thinking was the the LAD must be receiving blood from somewhere. So the assumption that the graft is occluded and there is no collaterals and the LAD native is occluded, so the LAD must be there. The question is where it is. And the usual thinking is, logical is, CT angiogram. So we did the CT angiogram, the graft is occluded, the circ graft is occluded, but the LAD is there. It's open, but it's severely narrowed. So I decided with her, let's go to the cath lab again. So this is the LAD, the circ, bifurcating with the OM. Very nice results from our partners, our colleagues. And they are still working very well. And this is the RCA. Again, it's working very well. No problem with the stent. This is the occluded venous graft to the OM. And voila, that's the venous graft to the LAD. It's just taking a very weird angle. Very tight lesion at the ostium. Very tight lesion at the anastomosis. And this was the missed graft that thought to be occluded. So what we did, I did 2 stents, one at the ostium and one at the anastomosis. 3.0 at the anastomosis and 3.5 at the ostium. The patient did well, but she was concerned all the time. She always said, so I did everything right. I went to the surgery, I had this, I still have some chest pain. So I said, let's go back and just have another look, make sure that you are being reassured. It was more of an emotional, I think, worried about it. So we did for her the angiograms and the stent was still open without any. This is the RCA and this is the venous graft that we intervened to the LAD. Still open, the patient was reassured. So the message, the final thoughts here. How do we evaluate for the grafts? If the patient comes to you and the grafts are assumed to be occluded or whatever. So, number one is read the surgical report. We always advise our surgical colleagues, just highlight where is the surgical. And I always try to document that in my notes, venous graft. And it's very important. We, cardiologists, cares about the proximal anastomosis. The surgical team, they always worry about how many distal anastomosis. And they tell the patient you had graft by 5. Yes, but there are some of them, they are skipped grafts, but we care about where is the proximal anastomosis. And this is very important to look for Y grafts like this one or the skipped grafts. And we were talking about in the hallway just a minute ago that the graft can touch more than one artery. The other thing is markers. Some surgeons, they use markers that they put for you, the graft. The other one is, it depends on experience that you have to look for the territories covered. And you know that this area is missing the artery. Where is this artery in this area? And that's why you have to keep looking and have a low threshold for aortograms. Just shoot an aortogram and look where is the artery. I doubt this graft would have shown on the aortogram because of the tight ostium. And I believe right now with the advances, CT angiogram is a very nice tool for graft. Personally, I did not used to use CT scans for grafts because of the challenging. Number one, higher radiation. You have to go for higher field to go for the LIMA and higher contrast load. And more important, you are going to be very good in evaluating the grafts themselves, but it's very limited to evaluate the native coronaries that are originally diseased. And they are going to be filled with calcium and you will not answer the question. So this is a nice thing that's for all of us to think about it. Which one is going to be first? Am I going to go for a CT angiogram first or just go to the cath lab and start fishing around and see what's going to happen? Personally, this is the second or third case that I had to go for a CT angiogram just to, after the cath, just to know what's going to happen. And I did that, and then we found that venous graft, and we just went there and we just stented. Thank you very much. I appreciate your attention.
Thank you, Dr. Fadi. We have 10 or 15 minutes for questions. Anybody? Dr. Ahmed.
Well, thank you. All my question, and I always face that dilemma, the dilemma of the LIMA steel. So the first question, do we need to open both? Do we need to open the native and we need to open the LIMA? What we will end up is we will end up with a competitive flow. Either your LIMA will degenerate later on or get shrunken in size, or your stent is not appropriate and your stent got occluded. So the point, do we really need to open both? Usually what I did, I usually open the subclavian because I like open subclavian. And as long as I cannot open it probably. What I did, if your stent is gonna cover the vertebral artery, if it's gonna cover the LIMA, so I will go for the native vessel. If I can't put a stent, the subclavian stent is better, the LIMA longevity is better, we need only to open the LIMA and we need to open both. I don't think if you guys have more experience about those patients. And what if this patient came after you open both and he's still complaining of chest pain? What are you gonna do? Thank you.
Dr. Raed,
Can I answer him?
shall we give a chance?
I'll answer
Dr.
Ahmed because
Ishraq?
this is a really very important point. When we have SVG graft actually to a CTO, and when we successfully open the CTO, we close the SVG graft. Why? Because the competition to the SVG graft, the flow will become sluggish. So it is an environment for the clot, and the clot immigrate distally to the native vessel. In these cases, we stop. Yes, we close the SVG. In LIMA, it is different situation. The LIMA, they have good flow from here, good flow from here, and the competition of those, it is not an environment for thrombus formation. But in this case, we had a stent to the subclavian, and this stent actually occluding the ostium of the left main, and the one image that we have after stenting, we have a sluggish flow in the LIMA. The patient will not complain anything, the claudication will go, no complaint in the chest, no chest pain because the LIMA is, because the LAD in the nativity is opened, but now we have sluggish flow in the LIMA. So maybe this is an environment for clot formation in the LIMA. So it's a questionable. There is no absolute answer for right or wrong, but it is great case, nice case to be presented from our junior and by our senior Dr. Hussein. So it's an excellent case.
Any comments, Dr. Hussein or Dr. Ishraq? Let us ask questions with the microphone. Ahsan. Yalla.
I'm just saying when we get both the flow coming from the LIMA as well as we fix the native LAD and left main, that we've seen quite a lot of atrophic LIMA, that you get the competitive flow and then the LIMA will occlude. I think I would agree with what Ahmed said, is that if I'm to fix it, I'll try to fix the left subclavian initially because we need to fix the left subclavian. If the result was not satisfactory, then I'll move into the left main. But fixing both and fixing the subclavian after fixing the native coronaries doesn't make that much sense to me.
Come along.
I just have a question. Should we make it a habit to, if we know the patient is going for surgery, to do a LIMA injection? Because many times we see that the LIMA has 2 or 3 branches that might cause also steel phenomena. And if we do this, we might also look at the ostium of the left subclavian and see if the LIMA is a good harvest or just don't worry about it.
Our colleague there.
اول شيء يسعد مساكم ويعطيكم العافيه. عارف الجميع صار تعبان بس سؤال بسيط. انا جراح بالتالي سؤالي why you didn't call your surgeon? It's a surgical case. You could not do stenting to subclavian. Why go for stenting? It's a left main. You need a surgeon. You don't need an interventionist. Thank you.
And it was discussed in a multidisciplinary team, so I assume there was a surgeon involved.
What are you going to do as a surgeon? ما دام الاوبشنز مفتوحه.
Dr. Raed.
Thank you very much. أول شيء دكتور إشراق, thank you. We encourage all of our fellows to be looking at you as a role model and present cases next meetings. That's pretty good. So we love your case. Excellent outcome. I have a little comment, and then I'm going to ask Fadi a question. I would, in your case, Dr. Ishraq, Dr. Hussein, طبعا, just open the subclavian. No, we don't need a surgeon for that. We just open the left subclavian. It is not a prohibitive angioplasty. It's a 10-minute procedure. Wait on the patient. If he's still having symptoms, I'll go to your second left main LAD stenting. So that's Fadi, question to you. I think you've been politically okay. So Fadi, thank you very much again. You've been politically correct with us today. So you have a patient, Cath, less than a year ago, came to your friends, to your colleagues, with a normal LV function. They Cath him, did RC angioplasty, did circ angioplasty. They most likely did an echo, and they found normal LV function, yet there is no blood supply to the LAD area. True? So at that time, 1 year back, they should have been looking for doing the CT angio. This is my remark on that. Thank you.
No comments.
I have a question to our colleague surgeons. Why did you stop leaving a landmark with the SVGs? That's the reason. Right. Okay. It's almost, it is not done anymore anyway.
I have a questions.
Right.
For Dr. Ahmed, nice case, but I will call this not perforation. This will call it vessel rupture.
This is a vessel rupture, yes.
And what happened exactly? Actually, the inflation of the big stent or big balloon, I don't know what that's really big. It was at the insertion site, at the implantation site of the graft to the vessel. So we should be very careful when we go with the graft and avoid the insertion site and inflation there. Sure. This is exactly. Yeah, but I mean, besides, this is the essence actually of the sutures or clips or whatever. So this is the essence, and the way to avoid it is actually we prefer to open the native vessel, not to go for the graft when you have any graft problem, especially when it is at the insertion site.
True.
For Dr. Fadi, the golden and the standard procedure actually to diagnose patient post-CABG is CT angio, not cardiac cath, as you know. I know that you know that very well, because it's easier actually to go there. Yes, the contrast is more, the radiation is more, but with cath, the contrast is more. Searching for the grafts here and there, many times we miss it, the grafts. So, and sometimes you need aortogram, so you need lots of contrast, lots of radiation. So the golden standard, I think you agree with me that CT is there. I'm trying to give points to everybody from all levels to get benefit of it. Thank you.
Thank you, Ryan. Any more?
Just have one more point to add to Dr. Ahmed's case. When you have post-CABG perforation, usually it causes localized tamponade. That's why sometimes the pericardiocentesis cannot reach the tamponade and causes localized tamponade, and you have to call the surgeon for that. Luckily, he could aspirate, but most of the times, or sometimes, it is localized tamponade, so pericardiocentesis may not work, and you have to call the surgeon to make a window pericardial.
Yeah, all right. Yes. Good point.
Yes.
But if we elaborate more for Muath case for the air embolus.
Last question.
How to manage it, not a question. How to manage it for everyone. What to do for everyone. When you have an air embolus inside the coronary arteries, what is the best way to manage it?
And Dr. Muath?
يعطيكم العافيه. هلا احنا اللي صار عندنا احنا ما في فلو من الاير اللي احنا حطيناه جوا المريض. احنا بنحاول نعمل بريك داون ذيس اير بابلز واذا قدرنا نسحبهم. هلا احنا حاولنا بالواير باي ويرينج putting buff nothing, balloon massage nothing. It was very rapid within 1 to 2 minutes just to aspiration catheter reverberation. We get aspiration catheter, we get some flow. If we get some flow, given adrenaline and adenosine and isocate distally, the patient improves the flow, and after that put inside the aspiration catheter with another aspiration, we get TIM3. In box, I didn't do it. You can use forceful saline infusion in the coronary to prepare your balloon or aspiration catheter.
That's good.
Okay.
Any other ideas? I have many ideas actually. So if you, just to utilize it, the best thing actually when you have air embolus and when you have it massive like this is to go with the aspiration catheter down the stream by aspiration catheter. And try to aspirate as much as you can, go distally. After that, by the aspiration catheter, you push it inside and you push saline in the distality so it will pop up the air out to the aorta.
Which was done, but the aspiration catheter, as you know, please give me the aspiration catheter, prepare the aspiration catheter.
You did this?
Yes. Balloon inside. Balloon.
Did not work?
It works after 3-4 times of aspiration catheter. Not from the first time.
Yeah.
Really, it was very high pressure air getting out the Y connector.
So the point is go with the aspiration, aspirate as much as you can air,
yes.
And then you go distally and push saline distally, so everything will pop out. Just to tell
Dr.
you.
Raed,
I did not understand
massage
this.
balloon, aspiration catheter, give medications and saline.
Okay, I think Dr. Muath, if you stay there for a second, I think you're lucky, your patient is lucky. The patient was going down the tube, and I think you had lots of luck that day, which is good.
Yes.
Just a little remark, when you give these patients nitroglycerin, it's not advised. You give a microvascular dilator, like a adenosine as you did, or nitroprusside. This will help the microcirculation absorb that big of a air embolus as much as possible, but nitro will make things worse for you because it decreases the perfusion pressure.
Nitro given the third medication. Our first medication is epinephrine, TIMI1, adenosine, TIMI1, adrenaline, blood pressure is good. We think about nitroglycerin. At this moment, aspiration more, it works.
Yeah. And do you know what has more adenosine in it while you are preparing for all of the above? Because I'm not sure that it is very available to you. The venous blood, if you have a venous sheath and you take the blood, it's full of adenosine. You can start just pushing them through the left main because it goes circ and LAD and helps you. Just try it. I hope you will not try it again or you had it again, but just try it if it happens.
Okay. Thank you, Dr. Muath. Thank you all. We finished the session of complication. Dr. Mahmoud Zraik wants to finish the conference. And I think you have to present things.
الله يعطيكم العافية. دكتور أيمن حمدان موجود. وين أيمن؟ حضر الكلوز ريم. طيب قبل بس ما أعطيك الميكروفون بصراحة أنا راح أعطيكم ماي إمبريشن. وجودكم اليوم بصراحة والمرة هذه أنا بحس إنه كل مرة أفضل من المرة السابقة. العدد أحسن. بصراحة بهنيكم على وجودكم معنا. ما راح أنا أحكي كثير لأن راح أخذ الكلمة للدكتور أيمن، ولكن بعد كلمة الدكتور أيمن في عنا appreciation، في عنا the best cases، وفي عنا technicians اللي بنعتبرهم إحنا الجنود المجهولون. المجهولون ولا المجهولين؟ المجهولون. anyway المجهولون. البوينت اللي بدي احكي لكم اياه انه بصراحه لهم دور كبير، بيشتغلوا معنا بالانترفنشن بالليل بالصبح. احنا يمكن المرات الجاي ممكن نعمل لهم سيشنز خاص فيهم. ففي 3 هدايا لهم للموست سينيورز، فالكل يكون ينتظر بعد الكلوزنج ريماركس. تفضل.
السلام عليكم. distinguished colleagues and guests, as we bring our cardiology conference to a close, I want to express my profound gratitude for your unwavering dedication and intellectual rigor. As we know, the heart is more than an organ, it is the very essence of life, endurance, and hope. Today we have stood together at the forefront of innovation, pushing limits of knowledge and clinical excellence. Our mission goes beyond treatment. It is a steadfast commitment to transform lives through cutting-edge research, relentless pursuit of precision care, and a powerful advocacy for patients' well-being. Every insight we share, every challenge we overcome reverberates far beyond this room, shaping the future of cardiovascular medicine. Let us leave this session inspired and driven to break new ground, to champion the health of hearts worldwide, and to embody the relentless spirit that defines us as leaders in this field. Together we hold the power to revolutionize care, save countless lives, and build a legacy of hope. Thank you for your passion, your expertise, and your enduring commitment, carrying this momentum forward with courage and conviction. Until we meet again, stay resolute, stay innovative, and above all, keep your hearts in this vital work. And if I may add, in these circumstances, please stay safe too. I would like to extend a special thanks to Dr. Mahmoud Zreik, the president of this conference, and all the faculty members, our team, all the chairs and co-chairs and panelists, all our device and drug companies for their time, dedication, and financial support. Without their contribution, this conference won't come to fruition. I also want to thank all the supportive staff and support members and our attendees for their dedication and time. Safe journey, and may our collective effort continue to make the heartbeat of humanity stronger than ever. Thank you, and God bless you.
الله يعطيكم العافية مرة ثانية. أنا بدي الهيئة الإدارية Organizing Committee يطلعوا على أيمن، رائد، رشيد إبداح، فادي القيسي. أين أنت؟ رائد، اعتزلت رائد أنت؟ ما أنت ما شاء الله رائد عوايشة كمان. أيمن بيعترضوا عليك، بقول لك أنت طلعت في كل السيشنز. في اعتراض من الاعتراضات اللطيفة جدا، أحد الأطباء اعترض على حالة الدكتور فادي على الدريل، بيبي دريل. بقول لي شو هالاسم هذا؟ بقول له حسب أنت كيف بتاخذها، يعني كيف تفهمها. هذا بريء، أنت بتفهمها بطريقة ثانية. اسمعني. anyway، إحنا بنحييكم. في مفاجأة صغيرة على كل حال. إحنا في عنا حطينا appreciation لاثنين من الطلاب اللي اشتغلوا بالinterventional research. هاي المفاجأة اللي ما حدا بيعرفها. طب خلينا نبدأ إحنا بالجنود المجهولون. في 3 الدكتور التكنيشنز اللي هو أشرف الهولي موجود. تفضل أشرف. أعطيني بالله وين أشرف؟ تعرفوه أشرف؟ المركز العربي، أكتف، نشيط، محبوب، مبتسم. سيدي هون هيك ناخذ صورة جماعية. أيوة. مين الثاني؟ فتح. الله يفتح عليك يا فتح. المستشفى التخصصي، تخصصي عمان، مش تخصص الإربد ولا تخصصي فلسطين.
واجي ناحيتكم.
ما تحمل الهديه اللي تروح منك. الثالث محمد قوقز. انت وين من اي مستشفى؟ اي مستشفى؟ مستشفى الحياه. الف مبروك. نحكي على الأطباء. بصراحة الأطباء الصغار ولا الأطباء الكبار ولكن أعمارهم صغيرة، الأطباء اللي قدموا حالات رائعة ولكن أعمارهم أصغر ناس عندنا كانوا بالمؤتمر هذا. أول وحدة الدكتورة إشراق، والله أنا بهني. إحنا المرة الجاية بدنا الفيلوز يشاركنا يا جماعة، فيلو الجامعة الأردنية، الفيلو اللي موجودين في المستشفيات، أهلا وسهلا، بندعمكم إحنا. هذه لا هذا مش بس، هذا بس كيس. ايوه ده ينقص. يلا الف مبروك. مين بتوقع مين الثاني صحيح؟ مين ينقص؟ معاذ ذبحتنا يا معاذ. وين معاذ؟ معاذ أنا كثير شاكر لك لوجودك المرة هذه. يعني إحنا بنحب دائما الكل يشارك بصراحة يا إخوان. المؤتمرات هذه هي ليس فقط للعلم، للتعارف، تغيير جو، انبساط. يمكن أنا نقطة واحدة كثير أنا بلومها على بعض الأطباء، إنه بلقي المحاضرة الإنونوريوم وبسحب حاله وبطلع. بصراحة هذا عدم احترام لنا إحنا، يعني هذه أنا بصراحة ننتقدها. تفضل يا معاذ. أهلا يا معاذ. بالضبط. مين؟ والله هو احنا اختلفنا من مين بصراحة، مين اللي قبل مين. أنا كنت مفكر منذر السعفين أكبر ولا أحمد حامد أصغر. أحمد حامد مش هيك؟ أنا أحمد حامد كنت مفكره أكبر بكتير، فطلع أصغر بكتير منك منذر. وين منذر؟ منذر وينه؟ والله مش شايف. فطلع أصغر منك ب7 سنوات. تعال تعال
إذا في حد بده يعترف.
أنا 86.
مبروك يا زعيم. الواقع احنا خرجنا عن القانون المرة هذه، ما حطيناش 3، حطينا 1 زيادة لأنه حالتي حلوة وجميلة وعملناها از ابريشيشن. انتم بتعرفوا الدكتور نزار شخشير؟ نزار شخشير انتخب قبل شهرين تقريبا، انتخب بالرابطة العربية للتداخلات القلبية ممثل عن دولة فلسطين. تفضل نزار. appreciation. well done يا زعيم. قبل ما نعطيكم ذا بيست، شو ضل عندنا احنا؟ ذا بيست كيسز. لا في مفاجأة. المفاجأة الاثنين اللي دخلوا معنا بالريسيرش في طالبة سنة السادسة اسمها رانيا العمايري، موجودة؟ أيوة رانيا، هاي مفاجأة لك رانيا. رانيا دخلت معنا بالكرونيك تيزر ريجستري ومثلتنا في دبي بالاي سي سي، وشي از اكسلنت سنة السادسة، وبصراحة فيري اكتف بالريسيرش، وبنهنيكي.
حاضر كل المؤتمر اليومين ثلاثة كاملين. بيرفكت.
اللي بيعرف مين هذا له جائزة أصلا؟ مين؟ لا 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 لا، احنا اوت. بس اعطيكم معلومة، احنا اخذنا قرار بالهيئة الإدارية لو اي واحد فينا قدم ذا بيست كيس ما عدا واحد، فادي اكسبشن هو. احنا اخذنا قرار انه ما بس مين بيعرف مين بالريسيرش من الشباب الصغار؟ حدا بيعرف مين الاسم؟ له جائزة. براءة جرار، وينه؟ براءة the most active امتياز، هو قدم مجموعة بيبرز، واحدة من the best papers قدمها، ومعي بكل الدراسات داخل معي بالانترفنشنال كارديولوجي. هاي مفاجأة. احنا يمكن العام القادم ان شاء الله راح نشجع الكلينيكال ريسيرش بالانترفنشن انا يمين. طيب احنا في عندنا ذا بيست كيس بالاجماع بصراحه، حتى بلس، في احسن من الاجماع، بلس 1 بلس 2 بلس 3. احنا بنحكي بالاجماع. هو شوف انا ورائد دائما مختلفين على كل حال، بس لما نطلع من الغرفه نتخذ قرار جماعي.
لا بصراحه we should thank everyone who presented. عنده courage خاصه في communication session. Thank you very much for everyone who presented بصراحه.
انتم ملاحظين لازم يحكي حكي شويه غير الحكي اللي بحكيه عليه. طيب دكتور حازم حبوب، بصراحه وين دكتور حازم؟ بصراحه بالاجماع اخذ the best of the best, to be honest with you. وهي تعتبر أول حالة بالمنطقة كلها بالشرق الأوسط بصراحة. ألف مبروك سيدي.
Thank you everybody. Thank you Dr. Mahmoud, all the faculty of PCI. Also I'd like to thank my colleague Dr. Ma'moon, my fellow Dr. Adayl Jabari for their excellent work, and thank you very much.
أعطيني الحالة الثانية. مين الحالة الثانية؟ أعطيني الأوراق أشوفها. مين؟ شو؟ وين الحالات؟ خلاص أحمد السعيد. اطلب أحمد السعيد. الدكتور أحمد السيد. أحمد سعد ولا أحمد السيد؟ بزبط، أحمد سعد وأحمد سيد. والثالث مين؟ مين مازن؟ ألف مبروك. مبروك. فادي القيسي. آخر واحد مبيوعة. في بياض يا جماعة، عملنا بياض احنا بصراحة، استثنينا اليوم مؤلفة قلوبهم. لا فادي بصراحة، يعني أنا to be honest with you فادي بيعجبني جدا، واحد من الأطباء المميزين اللي صدره دائما رحب متسع للآخرين، ولما ينتقدوه بأي نقطة بالانترفنشن، لأنه قدم حالات عندنا بالمورتاليتي موربيديتي بمستشفى التخصصي، أنا يعني باخذها فريندلي بساعة رحب، ولما هو كمان بدي criticizing anyone بطريقة بسيطة جدا. أنا بهنيك والله فادي، قدم 3 حالات وقدم كيس بصراحة أبدعت، الله يعطيك العافية. مبروك. ضل إشي حدا هون؟ خلصنا. احنا خلصنا الآن، بس ممكن ناخذ صورة جماعية. كل الحالات هذه راح تكون أبلودد. بالمناسبة موقعنا الكلاب انترفنشنال كارديوفاسكولار كلاب أخذ رقم واحد أونلاين من ناحية الكواليتي، فراح نعمل أبلود لكل البرزنتيشنز اللي عملناهم احنا. والله يعطيكم العافية، وخلينا ناخذ صورة جماعية.